Good afternoon, everyone. Welcome to this webinar on whole person integrated assessment of dual disorders. My name is Mary Ryan Woods, and I am a licensed alcohol and drug abuse counselor, a licensed clinical social worker. I am a board certified registered nurse, and I have a master's degree in human service administration. And I'm very happy to talk to you about this topic. I think it's so important because so many of the people that we work with are extremely complex, and there's no one magic bullet or one magic assessment that's going to provide us with all the information that we need. So if you have any questions, I believe you can contact Nahatica, and they can forward any questions to me. And also my email will be available at the end of the presentation. So our objectives today, that we will look at different components of what a whole person assessment includes. We will talk about some of the environmental issues that affect treatment for people with co-occurring disorders or dual disorders. And I will go back and forth with that language as we go through this presentation. We'll also talk about resilience and recovery capital for people with co-occurring disorders, because oftentimes it's a lot easier to build on the strengths that people have rather than have them sometimes learn new skills. So let's begin by talking about the challenges to assessing the whole person. And by the whole person, what I mean is, you know, the person's physical health, mental health, spiritual well-being, and just their environment as well. So very much similar to what ASAM talks about in terms of their dimensions of assessment. But one of the biggest barriers for assessment is an external barrier that we are all live under, which is funding and education. As many of you know, funding for mental health and substance use disorders in the public sector, there's two different block grants. In the medical sector, there's the funding for medical diseases, and then there's quote unquote behavioral health illnesses that get funded supposedly in an equitable manner, but we all know that that doesn't always happen. So we have these silos that have been created that affect all of us. Our education, when we look at our education, those of us who started out in the medical profession, we really receive very little education around substance use disorders and addiction, as well as mental illness. When we look at people who are primarily working with folks that have a substance use disorder or addiction, you know, their education and training may have some medical components to it. They may have some behavioral health, mental illness components to it, but it isn't often done in an integrated fashion. The same thing goes with people who kind of come into this sphere from the mental health world. They also don't get the same amount of education and training that is equitable for addictive disorders or medical disorders. And why is that important is because we're treating a whole person. We're just not treating a diagnosis. And unfortunately, in this environment of managed cost, we are often looking at how can we treat someone the most effectively for the least amount of resources, which doesn't make any sense, but that's kind of where we're at. But we have to keep in mind that we're treating an individual who comes with many strengths and challenges, and as well as they may have medical conditions. They may have mental health issues as well as substance use disorders. So the more comprehensive we can do the assessment, I believe the more effective treatment programming we can provide. So this is just kind of a visual for those of you who like visuals. When we think about co-occurring disorders, oftentimes we think about mental illness and substance use disorders, but oftentimes for a lot of our folks, there are also equally complex medical issues, whether it's people who are maybe older and have, vascular disease, coronary artery disease, as a result of their substance use disorder, or as a result of some of the mental health medications they've been on. There are a number of sleep disorders that people experience. We also know that there's a fair amount of people that have been exposed to alcohol in utero, and I don't know that we are really effective at diagnosing that post infancy. And we're going to talk more about that as we go along too. So just keep in mind that oftentimes the people that you are working with are bringing a lot of complex issues, which you probably already know, right? So the challenges of assessment, one of our biggest challenges is that, okay, we can do a comprehensive assessment, but then is there a continuum of care in our communities that will meet the level of care that the individual needs? Oftentimes people with substance use disorders and addiction are not treated in a way that provides creative case management and wraparound services that people with mental health illnesses often have access to. There can be a lack of coordination with other agencies due to funding or due to people just not having the staff to do those kind of outreach and networking meetings. And I know here in southern New Hampshire, there's a real lack of housing for people with both mental illness and substance use disorders that's affordable and safe. When we look about a lack of motivation for treatment, I think that that's a very loaded statement. I think everybody's motivated for something. We may not always have the treatment that provides the targeted motivation for that individual. People can also be affected by the medications they're on. People can be affected by, staff turnover. We can develop programs that are just based for action-oriented individuals who have made a decision to change, and they're made a commitment to change, and they've resolved all their ambivalence. Those are wonderful people when you get them in treatment. The definition of co-occurring disorders is very broad. It can mean a number of things. And for this presentation, it's going to mean 2 or more co-occurring illnesses or disorders. Our assessment tools are okay, but I think it's challenging for people who are in private practice who are in identified community programs to really have access to a comprehensive assessment tool that includes medical assessments, that includes sleep assessments, that also assesses for some of the other issues that we're going to be talking about. As we all know, the legalization of marijuana has made everything more complex. We are still experiencing stigma and discrimination for people that have substance use disorders as well as mental illness. Other competing needs can be billable hours. The staff are expected to produce, and they're expected to help keep the doors open. And so that the focus oftentimes, especially for supervision, will be on the administrative part of what's going on in the agency as opposed to the clinical part. Chronic health issues, both mental illness and substance use disorders, are chronic in nature, as well as many of the medical conditions that our folks experience along with those 2 co-occurring disorders. We all know legal involvement can be challenging to get a full assessment of an individual, and confidentiality and HIPAA, 42 CFR, they also bring their own set of challenges at times. And once again, the only other thing I want to say about this is the electronic medical record. And if anybody is working with a really robust, equitable electronic medical record for both mental illness, substance use disorders, and medical histories. I would love to know what that is. Because oftentimes it's been my experience that the electronic medical record is very robust in one area and less robust in another area. And if you're in a bigger agency, not everyone may have access to the full electronic medical record, so that can make it challenging too. So I want to begin by talking about something that, we've all heard a lot of over the last 10 years or so, and that's adverse childhood experiences. So that individual, that whole person that you're going to be assessing, we really need to begin with, how did they get to our door? What have they experienced prior to coming to our treatment program? And when we look at adverse childhood experiences, I'm just going to do this an overview. I'm sure most of you know this already, but there's 3 categories in terms of abuse, neglect, and household dysfunction. And so when we're looking at doing a whole person assessment, are we assessing for abuse? Are we assessing for neglect? And are we really assessing for household dysfunction? And these are all things that are going to affect that individual's ability to access treatment, and can also affect their, in terms of their longevity, right? Because we know that folks that have a high score of adverse effects typically end up with more chronic illnesses and a shorter lifespan. So types of childhood trauma, when we think about a lot of the folks that we work with, most of them have been exposed to some type of personal trauma in terms of physical, verbal, or sexual abuse, physical neglect, emotional neglect. And then when we look at doing a family history, do we do a comprehensive assessment of the parents in terms of their substance use disorders, the violence in the house, family members that have a history of incarceration or a long-term relationship with the criminal justice system, families, members that have mental illness, or the abandonment of the family. And sometimes you have to go back a couple generations because this pattern is repetitive. And that if we understand this is the 3rd or 4th generation who's experiencing this, then that makes the treatment interventions a little bit more complex. And we really have to think about, how do we interrupt that intergenerational pattern of abuse. Once again, just to review that, we look at if you look at the triangle on the right, we look at adverse childhood experiences, and then we look at what the social, emotional, and cognitive impairment that happens. The more adverse childhood experiences someone has, this pyramid builds on that. So they're more likely to have cognitive impairments and emotional and social impairments. They may adapt, high-risk behaviors. They may have more chronic illnesses, disabilities, and then oftentimes it leads to early death. So when we look at that, that's before the person ever comes to us. So when we begin to think about and conceptualize that person that we're trying to assess, it's important to look at those factors, because all of those factors are playing a part in the person that you're seeing and that their reaction to treatment. So social determinants of health are something that, we certainly look at. If you're doing the ASAM assessments, you're looking at these domains, but I think it's worth, once again, talking a little bit about, before the person comes to us, their economic stability. What are their resources? How much education do they have? And what is the quality of their education? Their access to healthcare, and what is the quality of that healthcare? And where is the neighborhood that they live in? And then what's happening in terms of social and community context. When we think about, especially like New Hampshire being more of a rural state, we have access in some areas of the state to really excellent healthcare, but then you get people who are in more rural communities where there's no public transportation, where there are limited clinics that people can go to. It becomes harder for them to access the level of care that they may require. And oftentimes our system of health doesn't look at that. We say, okay, I'm recommending an intensive outpatient program for you. And the person may have had a couple of DUIs, they don't have a driver's license. They're living on their own and they live in a rural area. How are they going to access that level of care and manage those recommendations? So once again, we look at societal conditions and structural conditions in terms of what are the policies and laws that affect the people that are coming with us, the data and surveillance, what kind of evaluations have been done in the past? Is there evidence to support the diagnosis that we end up with? Who are our partners and who can we collaborate with for this person, and what are their resources? So these are all things to think about too, because oftentimes reality doesn't match this, and we really have to be creative in terms of not blaming the individual for the lack of resources that they require in order to be successful in their treatment. So we think about safe housing in neighborhoods. I know here in the southern part of New Hampshire, housing is very expensive. Some of the more economical housing are in neighborhoods that aren't really that safe. Access to transportation, that's difficult. It's expensive, and people who live in rural areas just don't have that type of access. Exposure to racism, discrimination, and violence, that happens everywhere. And that's something we really need to think about when we look at the individuals that we're treating. What has been their exposure to education? What are their job opportunities? What are their income? Long time ago, the agency I work for was giving funding for a woman's halfway house. And unfortunately, that woman's halfway house was funded to reflect the men's halfway house. Well, the men all had job histories. Most of them had some type of a job skill or had a work history. And the women didn't have that, but there was nothing in the budget that provided for job training or any kind of education for women to enhance their ability to earn an income. So I think that's another thing we need to think about. Access to nutritious food and physical activities. We know that the healthier we eat, the better we feel, and the healthier we eat, the more our body heals, both our brain and our body. And then our people that we are working with, are they exposed to polluted air or water? We know there are parts of, especially in New Hampshire, where the water has been contaminated by a chemical company. And do they have access to fresh water? And then language and literacy skills. And then once again, do we have a well-developed continuum of care for people to access in our community? So co-occurring disorders, that whole statement is complex and confusing. It can mean anything, and it often does. And so it's important that we define it when we're talking about the people that we're working with. Co-occurring disorders can be defined as when someone has two or more disorders at the same time. So we could talk about somebody who has diabetes and hypertension and an alcohol use disorder. Comorbidity means that the interactions between these can be worse in the course of both. We know that someone who has diabetes and they also have an alcohol use disorder often have a more complicated withdrawal. They also have, it tends to exacerbate the symptoms of their diabetes. So that's an example of comorbidity. And one of the things, whenever I go anywhere and somebody says, well, yeah, I work in a co-occurring disorder program, but alcohol and drugs have to be their primary problem. I already know that, okay, this is not an integrated co-occurring disorder program, because once we start to conceptualize one illness being primary, we've already lost the whole kind of concept of co-occurring. People have hypertension, alcoholism, and depression all at the same time. And for reasons that we talked about earlier in terms of funding, education, and insurance, we look at, segregating the body from the mind, which doesn't make a whole lot of sense. We don't do that for any other illness. So if I have vascular disease and I have diabetes, we don't consider one primary and one secondary. They're both considered primary. And I think we have to start wrapping our heads around the fact that these people that we are treating are complex, and that they need integrated treatment to have the best outcomes for their illnesses. Sometimes there isn't a relationship between the co-occurring disorders. I mean, oftentimes we think about that, but I could have hypertension and depression, but one doesn't really affect the other that much. And as I said, these illnesses need to be treated simultaneously. And oftentimes there are medical issues that are overlooked, but they need to be integrated in with the behavioral health treatment. And I'm going to say this over and over again: treatment is most effective when it's integrated. Whenever we can build an integrated treatment program, and if we work in an agency or we work in a private practice and we can't provide integrated care, then it's really, really important that we network with the community so that the persons that we're working with have an ability for that wraparound care. So when we think about co-occurring brain diseases, we think about addiction. There's gambling, eating disorders, probably substance abuse, sex addiction, alcoholism, internet abuse, fetal alcohol spectrum disorders, traumatic brain injury, mental illness, vascular disease. All of these things can be floating around in somebody's brain at the same time. And if we think about a brain just having, okay, I've got a deficiency in my reward pathway, and that's what's driving my abuse of substances. Well, if I've had a traumatic brain injury, or if I have a fetal alcohol spectrum disorder, my brain is now wired differently, and it may respond differently, and my ability to interpret information may be affected as well. So I just think it's important that's why it's really important to look at the whole person and what has that brain been exposed to prior to the person entering your treatment. Once again, co-occurring can mean anything. It can be used, back in the 80s, a co-occurring disorder was somebody who had alcoholism and an eating disorder. It could be heart disease and cocaine dependence. I mean, there are so many things that are often conceptualized as co-occurring, when oftentimes it's multiple disorders that are experienced at the same time. And we really have to look at this in terms of a whole person. And it's also important to understand that when you have a complex person that presents complex symptoms, and they have maybe a high rate of adverse childhood effects, they don't have access to a lot of social determinants of health, we can't do it all. And we have to really find that network of individuals and programs that will help build that effective treatment platform for that person. Having worked for a long time with people with co-occurring severe and persistent mental illness and substance use disorders, there were a lot of myths that I entered the mental health world believing, because I was coming from the addiction world to treat people with co-occurring mental illnesses. But based on the research that has been done at Dartmouth and other places, there are one of the myths is that there's no decline in substance use, and that's not true. If you think from a more harm production perspective, people do decline in their substance use. They may not come to total abstinence right away, but they tend to, with age, decrease their substance use. There is a high rate of incidence of suicide with people who are actively using substances, but that's true whether someone has a co-occurring disorder or not. They also, people with co-occurring disorders don't have access to really good medical services. Sometimes they're just sent to an emergency room and it becomes a revolving door and you treat that symptom, but they never get the underlying cause of the illness. And oftentimes people with co-occurring disorders don't have a lot of satisfaction with treatment because they get, because of turnover of staff, because of changes in programming, you know, decreased access to care. I think there are a lot of reasons why people end up with believing some of the myths about people with co-occurring disorders. When we think about whole person assessment, I would suggest that we think about spirituality, the person's medical history, certainly their trauma history, as I talked earlier, the adverse childhood experiences. What are the person's social determinants of health? Their use of substance, their misuse of substance and addiction, and what has been their mental health history as well. I mean, we can also look at their education history, their criminal justice history, anything their certainly their vocational history. That's what that person is bringing to our door. And the more we understand what they've experienced before they get to us, I know I keep saying this over and over again, the more effective our treatment planning can be. So when we look at, okay, so the individual has a biological, behavior, and social environmental components that they experience, but that's also affected by what the family experiences, and then what the family experiences in the community, and then what the community experiences in terms of population health. So, someone who grows up in a mining town in West Virginia, what their resources are much different than somebody who may grow up in Hanover, New Hampshire, and what they have access to in terms of social determinants of health. So, once again, being able to look at the individual, the family they bring in, the community that they've lived in, and then the actual population of that area. So from my perspective, I think the most effective way to treat complex co-occurring disorders is with a multidisciplinary team that has a true integration of a treatment plan and an assessment, and that you include, in terms of this multidisciplinary team, you include the individual, their family, however they define their family. If you're not in an integrated treatment environment, then you work with an integrated treatment provider. If there is one, a mental health provider, a substance abuse treatment provider, medical, housing, veterans, HIV, legal providers. Everybody has a role in that individual's recovery. And I think it's important that we find ways to communicate on as broad a term as we can, so that there's one-stop shopping for this individual, so that they don't get bounced from one agency to another, because that contributes to a lot of treatment dropout and dissatisfaction as well. So when I talk about a multidisciplinary team planning, we have interventions that include both mental illness and substance use disorders, physical health, support services, recovery services. We look at stage-based interventions. When I talk about that, I'm talking about stages of change. So we match treatment with where the person is in terms of their process of change. That we look at interventions that are measurable and objective, and that they're inclusive of all of that individual's goals for mental illness, substance use, housing, employment, recovery, whatever their goals are, maybe for education, that it really has that individual driving the treatment. In the best world, no matter where you work, it is a norm rather than the exception to see individuals with dual disorders, so that you understand, whether I'm in private practice or I am working in a large behavioral health care organization. My assumption is the person's coming to me has some type of co-occurring disorder, and I will assess them in, or I will assess it out. I mean, you may have somebody who's young and just starting to develop symptoms, and maybe truly all they have is a depression or a bipolar disorder, which is great. But always assume that there is one, and then rule out everything that could also be causing those symptoms. Otherwise, a lot of folks end up with undiagnosed co-occurring illnesses that then kind of get in the way of effective treatment. So when we think about this, this is just a visual, so that we understand that the head and the body are connected, and that it's important for us to understand as healthcare providers that, serotonin can be manufactured in the gut. So if we don't understand how the body is producing neurotransmitters, then how are we going to, if we're just focused on the brain? And I think it's just really important to understand that we can't just compartmentalize an illness or a diagnosis, because the whole body is affected. So once again, talking about the whole person assessment, or a co-occurring disorder, we talk about certainly, the things that we've all been trained to talk about. What substances have they been using? When did they first start using them? What has been the effect of those substances on the individual? They have symptoms of mental illness. Once again, looking at when those started. We look at family history in terms of, mental illness, substance use disorders, domestic violence, chronic medical conditions, genetic conditions, and going back a couple generations can be helpful if you can get that. We look at diet and nutrition. There are so many additives in our food that contribute to brain fog, obesity, and other things, that it's important to look at. If somebody can't afford an optimal diet, and maybe their brain hasn't healed enough so they can access the medications we're giving them, or to be cognitively sharp enough to do CBT or some of the other therapies that we may be doing. Sleep is so important for all of us, but oftentimes people with severe and persistent mental illness and substance use disorders could have a sleep disorder. We know that alcohol interferes with the sleep cycle, and that, back in the day when I worked with a lot of people who really then had an alcohol use disorder, sometimes it would take months or years for their sleep cycle to return to a normal pattern, and that they would often have dreams of using, they'd have nightmares. It was hard for them to feel good because they just weren't getting good sleep. And that's all due to the effect of alcohol on the sleep cycle when somebody's using alcohol. We also know that, the same thing happens with amphetamines, that they can also interrupt the sleep pattern. It'd be really difficult for people to regain a normal sleep cycle. That can be part of the post-acute withdrawal process. Another thing that can happen frequently, especially with people who have gained a lot of weight, or who are maybe a little bit older, that they develop sleep apnea. And that's something that can be assessed for. There's instruments to do that. There's sometimes just watching somebody, if you're lucky enough to have somebody fall asleep in your waiting room. I know this happened where I was working once, and as the addiction provider, I walked by and I thought, oh my goodness, he's been out using all night. He's nodding off, he's asleep in a chair. The doctor walked by and said, oh, he must be on too much medication. Maybe I need to adjust the dose. He's having side effects. He's really sleepy. The nurse walked by and she stood there and watched him, and we all went into a team meeting. She said, he's got sleep apnea. When he's sleeping, he's not breathing. And she counted how long it took for him to breathe how long between breaths it took him. So we sent him out for a sleep assessment, and sure enough, he had a sleep disorder. So the addiction person, me, was wrong, the doctor was wrong, but the nurse was right on. So I think, don't just assume something when you see it. It's important to dig down a little bit. Same thing with a medical history. If you're working with someone who is using drugs intravenously, they can develop, endocarditis. They can develop really significant wounds at the site of injection that can take a while to heal. And in addition to the things that we typically see in terms of diabetes, hypertension, thyroid disorders, tuberculosis, and all those other things that we screen for. In terms of a spiritual history, I think that's really important because of I once worked with people that had severe and persistent mental illness, and I was told not to bring up God because it would just inflame their psychosis. And coming from the addiction world, where we talked about a higher power all the time, I found that strange and uncomfortable, but I didn't bring up a higher power or anything related to it. And we were doing a group one day, and we were like doing a morning check-in, and two of the women talked about how they'd been on their knees that morning praying and asking for help to get through the day. And it was like, wow, there's a disconnect here. This is what people are doing, but this is what I'm being told. And I think to a certain degree, everyone has some type of a spiritual connection, whether it's to the environment, to a higher power, to whatever kind of helps get them through the day. And if we can understand what that is for the individual and help them access that and build on that, that's part of the recovery resilience that we're looking for. I mean, isn't that why the 12-step groups work so well? I mean, it's a spiritual program that if you're lucky enough to be exposed to those 12 steps and understand how living those 12 steps makes your life a whole lot easier, then that's a blessing. And oftentimes you'll hear people say they're grateful to be an alcoholic, or they're grateful to be an NA, and that's one of the reasons why. So the other thing that I strongly advocate in terms of a whole person assessment is getting a hold of that individual's old records. Back in the day when we had paper charts, it was a little easier. But if you don't understand the person in front of you, if you don't see how they were presenting 5 years ago, or what their substance use was 5 years ago that's been documented, then it's going to be a little harder to really understand the symptoms that you're observing now. I know sometimes with electronic medical records, it's hard to access old records, especially if they've been in a different agency, but it's certainly worth the time and effort to do that. Excuse me. When we talk about traumatic brain injury, we'll go into that a little bit more. It's important to think about that in terms of the individual that's in front of you, and being able to assess their strengths. That's so important, because regardless of where somebody is in the continuum of their substance use disorder or mental illness, they do have strengths. They may not be using them in the most positive way, but they do have strengths. And if we can understand what those strengths are, then we can build on them. If we can help focus on resiliency, how do we build resiliency as opposed to focus on the illness? That's also a very positive, forward-moving way to get the person into treatment and recovery. Legal issues, we all know that most of our folks have some type of legal issues, and being able to develop if the legal folks can't be part of our multidisciplinary team, it's really important that we have releases of information and we can talk with them, so that this individual can get the most that they can from the legal system, but also so that things don't get misinterpreted either, and be a hindrance for this person's recovery. And then whenever possible, connect with other providers. That's just really, really important. When we think about co-occurring disorders, we know that substance use disorders can cause psychiatric symptoms and can mimic mental health disorders. So if you have somebody who's coming into treatment and they're very manic, they're loud, and they're pacing, depending on what silo you've grown up in, you may think, oh my goodness, this person's having a manic episode, or you may think, oh my gosh, this person's just been using amphetamines. We need to do a tox screen. So it's important to be able to rule both out or in, depending on your perspective. I think that somebody who has been using methamphetamine for a long period of time, or cocaine, may have periods of paranoia and psychosis. We know that the high potency marijuana that's available has caused psychosis in a lot of younger people and older people as well, that antipsychotics have been able to treat some, but for a lot of these folks, it's triggered a gene that they're not going back to a quote unquote normal brain. As a result of the substance, it's triggered the gene, and now they have a psychotic diagnosis of psychotic symptoms. We also know withdrawal from alcohol and other substances can produce hallucinations. And so, it's just important that whatever symptoms you're seeing in front of you, don't be quick to judge. Do a really thorough assessment, so that you really understand. Maybe the person has been using methamphetamine and they also have a bipolar disorder. I mean, you don't know until you do that full assessment. So the other thing with withdrawal, we know that some withdrawal can be protracted, and that in terms of somebody's mood, in terms of their sleep, in terms of their cognitive ability, their ability to focus. So those are things to think about too, when you've got somebody who's maybe been through treatment and they're coming to you an outpatient, and they're not on top of their game. Think about, maybe this is just a protracted withdrawal that they're experiencing as well. So, this is what you all know, that that depression, anxiety, paranoia, hallucinations, and agitated behavior could be a mental illness, but it also could be withdrawal symptoms, right? And we also know that medication has side effects that can be interpreted as substance abuse, whether it's sedation, insomnia, a change in appetite, abnormal body movements, irritability. So once again, do your homework and find out what this person really is experiencing and what they've ingested prior to seeing you. We talk about spirituality. I've talked a little bit about that, but spirituality can be defined as the part of us that searches for meaning. And almost everyone that I've worked with, whether in an addiction program or a co-occurring program, everybody's kind of looking for meaning. And we used to talk about that hole in your soul, that you're trying to find that plug, if you will, that makes you feel whole, that makes you feel complete, that makes you feel comfortable in your own skin. And for a lot of folks, they find that through some form of spirituality. And in terms of spirituality, you recognize that there's a force that exists beyond the material world. It encourages hope and purpose. If you begin to look at spiritual interventions, they can foster positive emotions, coping skills, and recovery. And spirituality and religion are not the same. This is an aside. Just read this book that I picked up somewhere about this woman who her parents immigrated from Germany in like 1930. Let's say 37 to America, and neither one of them wanted her. It wasn't a very good relationship. They got married because they had to, and so the mother ended up taking the child, she was 2 at the time, back to Germany to try to see if one of the relatives would take her. And so this girl got dumped on one of the relatives. She never really, nobody ever hugged her or really emotionally connected with her, but she always had this presence that she felt something was with her. She felt like she was being protected. She had this premonition. There was bombing one night, and she had this premonition that they needed to leave the town and go out into the fields. And they did that, and the place where they were living was decimated by bombs. So she had these different experiences through her life. And she always focused on this feeling that there was something bigger than herself that was guiding her. She ended up coming back to America after the war, and she got involved in some spiritual groups, and she was always hopeful. She was always trying to find the silver lining, if you will. And she really credits her spiritual connection with having survived the trauma of being abandoned by her parents, being abandoned by her family in Germany, having to come to America, and then being abandoned again by her parents. I mean, it wasn't a great life, but she certainly made the most of it. But I guess what I'm just trying to use it as an example of, how we think is how we feel. We all know that, right? So that's important. And the other thing that often spirituality and religion are not the same, and that's something you all know, but I just wanted to state that because you can be very religious and not be very spiritual, right? And you can be very spiritual and not be very religious. So they're just totally different things. So when we think about in terms of spirituality, can often emphasizes the healing of an individual, not just the disease. So it's, when we think about the 12 steps, it's not just about, you put the plug in the jug. It's about how you live your life. It's how you deal with resentments. It's how you reach out to people. It's how you accept yourself for who you are. And that if, people who are in long-term recovery or even early recovery, they feel different about themselves. If you've known them when they were using, you know them afterward, they're different people. And that's a good thing. Spirituality can be experienced in meditation, prayer, yoga, nature, art, community, music, all those things can be conduits to spirituality. And when we think about religion, we think about that as the structure, the rituals and beliefs that are created in response to the spiritual dimension of life. And some people find that structure and ritual very comforting and rewarding. It can be part of your family history. It can be part of your family culture. And for other people, they find they may have had experienced some type of religious abuse, right? And they're not attracted to that structure, but they still have a strong spiritual part of their life. So once again, if this is something we can tap into, it's just building that block for resiliency and recovery. So just to review, spirituality promotes a positive worldview, which is so important. It can help us make sense of difficult situations. It can give purpose and meaning. It certainly discourages maladaptive coping, it enhances social support. It promotes other directedness, so we're not so self-absorbed, and it doesn't have to all be about me. The other thing that I love about this, especially if you're familiar with the 12 steps, it helps to release the need for control. There are some people in my life that they have to control, every aspect of what's going on, whether it's a women's group that I've been part of or whatever. There's just some people that has to be done their way or the highway. And not only is it uncomfortable for those of us around them, but they're not finding a whole lot of joy in what's going on either, because they're just so anxious that they just need that control, right? And being thankful, that's, we all know, makes life a whole lot better. And spirituality can provide hope, and hope is one of the key components to what makes treatment effective. So there are some spiritual assessments, and I've got them listed here. If you want to Google them, they're there, they're available, and for the most part, they're free online. So just an example, the FICA, which is faiths or beliefs, the importance and influence of beliefs. It also assesses the community that the person's in, and it addresses like core issues. Fact, is somebody active? Are they available? Are they accessible? Are they coping? Is it comfortable? Are there more conflicts or concerns? And then what is the treatment plan? So this is just an example of the FICA spirituality assessment in terms of what is your faith or belief? Is your faith or belief important in your life? Are you part of a spiritual religious community? So these are just 4 questions that are very simple. They don't take up a lot of time, but it gives you another dimension of the individual that you're working with. So medical assessment. We know that people we work with are very complex. I know I keep saying that, but it's true. So when we think about the whole person assessment, we typically always assess for somebody being a risk to themselves or others, right? That's that's mandatory. And then we look at what the presenting symptoms could be for their mental illness or their substance use disorders. We may do some family history. We look at what are the presenting symptoms of a medical disorder. And I think this is where some people will feel very comfortable and other people feel like they may not have the experience or education to do that. But it's really important that you get a hold of a medical screening form, if nothing else, that you can then, the individual can, certainly answer the questions that will give you an idea of like, okay, there's something going on here and I need to refer out. Looking at someone's past psychiatric history and trauma history. When we're doing back in the day, we used to do a comprehensive psychosocial evaluation. I'm not sure that they get done to the same degree that they used to, but basically, we're just looking at, let's find out as much as we can about this individual before we make a diagnosis. And we look at cultural considerations. What's their legal status? Are they currently on medication, and are they having any side effects? And what are the doses of medications? Are they taking them regularly? Who is their provider, and can we get a release of information to talk with that provider? Being able to look at the history of treatment and recovery. Can we get releases of information to get their previous treatment history, whether it's medical, mental health, or substance use disorders? And then what are their barriers to recovery? There's assessments we can do for that as well, because those are going to help drive the treatment plan. If we already know that there are existing barriers, we're going to have to find a way to mitigate those or remove them for the person to really maximize their recovery experience. And then what currently do they have that are facilitators of recovery? What are the things that they have going for them that we can enhance or get them reconnected to that will help provide that foundation for recovery? So it's a lot. I mean, and you may or may not have time to do all this, but at the end of the day, once again, in a perfect world, you make time to do it, right? And I know there are competing issues in terms of billable hour, the amount of sessions insurance will give you to do assessments, but this is where advocacy comes in, and the more we can understand this, more effective our treatment plan and experience can be, and in the long run, it's more cost effective. So when we think about symptoms of each disorder, whether it's mental health or addiction, these are just simple things that you all know. You look at the intensity. Are the symptoms mild, moderate, or severe? What's the duration and frequency? Does your agency have the capacity to treat and or monitor the level of medical disorders, mental health disorders, and substance use disorders? And if you do, that's wonderful, and you can have a multidisciplinary team. And if you don't, that's where it's really important to network out in the community. So medical complications that people will often experience when they're coming to us for treatment for mental health and substance use disorders, or co-occurring mental health and substance use disorders. Diabetes is often seen with our population. Heart disease, especially as people age, and that can be true even with people who are in long-term recovery. If you know people in long-term recovery, you'll find that a lot of them have chronic vascular disease. They may have COPD, and that's, even though they may have been sober 25 years, they still are very susceptible to these chronic conditions. Epilepsy can be a co-occurring issue. It may be people may have seizures as a result of withdrawal, or people may come to us with a seizure disorder. A chronic obstructive pulmonary disease, which because of the amount of smoking, both nicotine, crack, and marijuana, and God knows what else they're smoking. All these have toxins and carcinogens in them, and it can lead to chronic obstructive pulmonary disease even after they've been sober for a while. Parkinson's disease, people can come to us with Parkinson's disease, liver and kidney disease. We hear about cirrhosis, we hear about, people with kidney stones and, poor kidney and liver functioning. Certainly we assess for sexually transmitted diseases. Xylazine, if you're working with people that are using xylazine, they frequently have skin infections on their extremities that can become very severe to the point of amputation. So that you want to make sure that if you're intaking somebody and they say they're doing this, get them, if you can't check out their extremities, then have somebody do that, because they're very high risk for skin infections, hypertension, obesity, chronic pain. Um, so many people that we work with also experience chronic pain, and being able to connect with an effective chronic pain management group that understands addiction is so it's amazing if you can find somebody that can do that, because oftentimes the pain meds cause chronic pain, and it's very complex. So finding people that providers that understand the folks that we're working with and networking with them is great. Anorexia and bulimia, we often see folks that have either one of those. Thyroid disease is very common, especially people that have been on medications for a while. Gastrointestinal disorders, cancer, endocarditis, which is the inflammation of the heart, which can happen and frequently happens with people who are using IV drugs. And oftentimes they require a port and IV antibiotics for weeks. So these are all things to think about. Screening tools, if you have access to lab work screening, these can all of these tests can give you a picture of the person's current health and maybe the effect of their substance use and or mental illness on their current health. So these are just some of the things that you might want to consider if you can't do it at your agency. If you have the ability to network with a ANRP or a clinic that can do this type of lab work, being able to do an EKG to look at cardiac functioning, even in young people, especially if they've been using amphetamines, you really want to get a sense of how their heart is working. Doing chest x-rays, looking at symptoms of withdrawal, using a breathalyzer. They're wonderful little tools that can help you get a sense of what the person in front of you has been drinking. And then carbon monoxide monitoring, which is another tool that you can blow into, and you can see, especially if people are smoking a lot of nicotine, you can get a sense of what their blood oxygen level is and the amount of carbon monoxide that they have floating around in their vascular system. So just so you all know, the leading causes of death and disability and the leading drivers of the nation's 3.8 trillion in annual healthcare costs are chronic illnesses. And just I'm not going to get into this, but an acute illness has a sudden onset. It's there's a cure usually for it. It's a short duration. It's usually the medical provider comes in and does an intervention. So if you think about appendicitis, that's an acute disease, right? The person comes in with the symptoms, the medical team makes the assessment, they have surgery, and then they never have appendicitis again. Somebody has gallstones and they have severe pain and their gallbladder's inflamed. Well, they have surgery, they take the gallbladder out, and they'll never have gallstones again. So that's an example of an acute disease, right? A chronic disease are what our folks experience. There's a gradual onset. There's not really a cure. It's a lengthy course. The course of treatment goes up and down. The person has to work with the team, but primarily the person has to do a lot of behavior changes to treat that chronic illness. And the person, depending on their adherence to the treatment plan, may have returned to as normal as likely as possible. Or if they don't, then their future is certainly uncertain, right? And so unfortunately, our behavioral healthcare system is designed to treat acute illnesses, not a chronic illness. And so that's one of the huge barriers and impediments that we experience as providers. So when you look at what the lifestyle risks are for chronic diseases, tobacco use, poor nutrition, lack of physical activity, and alcohol use, excessive alcohol use. So isn't this the folks we work with, right? So once again, assume there's another chronic illness going on, whether it's a medical condition as well. So just the definition, a chronic disease persists for a long time. It's one lasting 3 months or more. It's generally cannot be prevented by vaccines or cured by medication, nor do they just disappear. 88% of Americans over 65 years of age have at least one chronic health condition. So, eventually I guess we all get one, but the folks we are working with have them when they come to see us. Chronic illnesses are complex, requires a long game approach. It requires, wraparound services, and it requires interagency communication and cooperation and coordination. These folks don't do well in a one-stop shop setting that just focuses on one of their many challenges. They need a comprehensive, integrated treatment plan and agency if possible. Okay, so I talked about this being designed of models of treatment. There's the single model of care, which was believed that there was a primary disorder, and I've talked about that before. Back in the day, we used to think that people who had an alcohol use disorder and were depressed, I remember going to a conference hearing a physician say, if the person's still depressed after a year, then we can probably rule in depression as an independent primary disease. So we don't think that anymore. Then there's a sequential model of treatment that acknowledges the presence of co-occurring disorders, but treats them one at a time. So I know you have depression and you have a substance use disorder, but once you get sober, then we'll treat your depression. And then there's the parallel model of treatment where the mental health disorders are treated at the same time as co-occurring substance use disorders, only by separate treatment professionals and separate agencies. So this unfortunate individual ends up having a treatment plan in 2 different agencies with 2 different teams that may or may not be coordinated. And this person may be having a lot of expectations on them in terms of a treatment plan. So once again, just assume everybody has a co-occurring disorder and screen those disorders out. And you'll have a much better presentation of what that person is experiencing. So when we talk about brain illnesses, there's so much of this that our folks experience that I'm not sure we really assess to the degree that may be helpful for that person. We look at fetal alcohol spectrum disorders, which we have fetal alcohol effects disorders, which is where the person has the smaller eyes, the big gap between their nose and their lip, the physical characteristics that most babies are assessed for at birth. And then you can say, okay, this person has fetal alcohol effects disorder, but there are many more people who have fetal alcohol spectrum disorders, and they don't have that typical physical presentation. We also have traumatic brain injury. We're going to talk a little bit about that, and brain and body inflammation. I mean, we're learning so much more about inflammation and how it affects our ability to heal, our ability to absorb medications. I mean, it's just fascinating what's going on with that. Trauma, we all know about trauma. But it's important to really look at how that is affecting the individual in front of you. Dementia, some of our folks are more susceptible to symptoms of dementia, and ruling that out at times, if you've got somebody who is just not able to remember, they're finding themselves disoriented a lot. It's important to look at that. Vascular disease we've talked about, and I just say brain inflammation again because it's just really important. So just looking under the hood in terms of how brain science informs our treatment, We know that the brain's reward circuitry regulates both the feel-good effects of a drug as well as the extreme physical and emotional discomfort experienced during withdrawal. The emotional signs of withdrawal can flare up for months or even years after attempts to quit, and these factors play into continued use of taking substances, craving, and relapse. Each person struggling with a substance use disorder has his or her unique constellation of social, genetic, and psychological factors that make some treatments more effective than others. There's no magic bullet. There's no one type of treatment that's going to be more effective than another. It really has to be individualized. And when you do that, then that's when you provide effective treatment. And the more we understand the brain science of addiction, the more likely we are to come up with more treatments that can help a broader range of people. So, science is good when it's been well researched, right? So some of you may have seen this slide. Extreme left is the cross section of a person with a healthy brain, and you can see how vibrant it is. There's a lot of activity. Somebody who's been abstinent from meth for a month. Not a lot going on there. There's some activity, but still hasn't cleared. And then 14 months of abstinence, you see the brain healing, and you see the person getting their cognitive abilities back, right? So fetal alcohol effects disorder and fetal alcohol spectrum. I could go on about this forever because I don't think we do a great job of assessing for this as substance abuse providers. That's just my opinion. But some experts estimate that about 1% of Americans suffer from a fetal alcohol disorder, about 4 times as many people as those that have AIDS and HIV. There are 3 to 5 times as many people with alcohol-related neurodevelopment disorder, which gets misdiagnosed all the time. And it's something I really hope in the future we can get more in tune to. So fetal alcohol spectrum disorders are, they're a group of diagnoses that when we talk about them, they'll be very familiar. But 1 in 20 kids in school may have a fetal alcohol spectrum disorder. And when we talk about that, the people that have mental health problems, they have trouble with the law, they have inappropriate sexual behaviors. They are often misdiagnosed as oppositional defiant, attention deficit disorders. They have a whole array of conduct disorder diagnoses. So what we know about alcohol, right, is that no amount of alcohol and no time in the pregnancy has been established as safe for the fetus. Less obvious and seemingly milder fetal alcohol damage is sometimes called fetal alcohol effects, alcohol-related neurodevelopmental disorder, partial fetal alcohol syndrome, or static encephalopathy. So once again, we have these terms and diagnoses that tend to add to the confusion as opposed to the clarity. So fetal alcohol spectrum disorders are lifelong, and what's important is that there are structural differences in the brain caused by the exposure to alcohol in utero. These are structural differences. These are not quote unquote normal brains. And these differences can include impaired cognition, profound lack of self-control, and great difficulty linking cause to consequences. As many as 5% of all children born in the United States have some degree of this. And significantly higher rates have been found at-risk offender populations. So it's really important. It's also important to, which is another thing to look at, is that individuals with alcohol-related neurodevelopmental disorder may look normal and have seemingly normal intelligence, but their impaired brains can result in learning disabilities, impulsivity, lying, stealing, tantrums, violence, and aggression, inability to predict consequences or learn from experiences, lack of conscious, and being highly susceptible to addiction. Okay, so just think about some of the people that you work with that have been resistant to treatment. Maybe it's just because their brain isn't functioning, or it hasn't been developed in a normal way. So these are just some co-occurring disorders that often get mimicked, that people get diagnosed with, as opposed to looking at the fetal alcohol spectrum disorder. So I've talked about some of this, but it's really important to look at, if you've got somebody who fits that symptom profile, to try to dig into their experience in utero if possible. And then those of you who are working in criminal justice, you're going to see these folks a whole lot more often than those of us in the community. These folks are often unrecognized, undiagnosed, and untreated in the criminal justice system. They have an impairment in their ability to for adaptive functioning, cognitive functioning, and social issues. These folks, you know, they have high impulsivity, so they're often arrested for sexual misconduct. They can often be put on the register for sexual predators. When, yes, the behavior is that, but they don't have the cognitive ability to understand where I stop and you start, or what the consequences are for my behavior. So these folks need tremendous wraparound care. They need a lot of it's for life, right? And there's the National Organization of Fetal Alcohol Spectrum.org, nofast.org, which has great information on these. And I know if you want to learn more about that, then you can really get into it. But this just shows you what complex wraparound services are needed for people that have FASD. And traumatic brain injury, I would like to say that the majority of the people that we work with have had some type of traumatic brain injury. So it's a disruption of normal brain functioning that occurs when the skull is struck suddenly, or thrust out of position, penetrated, or struck by a blast or pressure waves. An estimated of 1.7 million TBIs occur annually in the United States. And every age group, TBIs are higher for males than for females. Among the age groups that have the highest proportion of TBI are adolescents, age 15 to 19, and adults age 75 or older. Sports-related TBIs alone estimated between 1.6 million and 3.8 million each year. So you think about the young folks that we have that come to us, and they've been active in, whether it's males or females, soccer, hockey, lacrosse. How many times are they getting whacked in the head with a stick or a ball? And football, and that's a whole other thing, right, with the concussions. But you know, that's why when you do a comprehensive whole person assessment, when you look at your strengths, their strengths, you want to say, okay, well, what are you doing for fun? What are you doing? Are you involved in sports? You know, and being able to look at that. The people who may have a seizure disorder, if they've fallen and they hit their head, it's not uncommon when somebody who's, you know, grossly intoxicated to lose their balance, fall down, hit their heads, a chair, a table, the sidewalk, or whatever, and it's they get in fights, and they get they get boxed in the head. So it's really important to rule this out. Once again, just assume they have had it till you prove they haven't. And then we get into just a traumatic brain injury could be mild, moderate, or severe, and this just tells you how to determine how they determine what's a mild loss of consciousness and moderate and severe. So the links between traumatic brain injuries and substance use disorders. History of substance abuse is a risk factor for traumatic brain injury. Alcohol use at the time of injury is common with somebody who has a traumatic brain injury. Prior traumatic brain injury is common among individuals in substance abuse treatment, and that's why it's so important to assess for it. Substance abuse is linked to worse outcomes from a TBI, and substance abuse is linked to recurrent TBIs. So once again, this is something we should be educating our clients, patients, participants on in terms of taking care of their brains. And then once again, if you're going to, they say they have had a TBI, these are just questions you can, so a couple questions you can ask. How severe was the injury? How fast and how well did you recover? You know, what age were you at the time of the injury? Were there other injuries in the body from that same traumatic event? And just being able to say, did you lose consciousness? Did you not lose consciousness? So, you know, just take a couple minutes and just try to determine what the impact of that head injury is. My goodness, brain inflammation and addiction. You know, we're learning so much about just brain inflammation without anybody drinking or having a mental illness, just having a healthy brain. That it's just important that we begin to look at how do I take care of my brain, right? And when there's inflammation, the brain will let us know through symptoms, like problems with concentration, memory impairment, mood dysregulation, and anxiety that can impact wellness skills, social skills, activity, daily living skills, vocational and educational skills, recreation, recovery skills. So if you've got somebody in front of you who's experiencing some of this dysregulation and impairment, begin to look at, oh my goodness, what are they eating? Or is it a high carbohydrate, high additive diet where they don't have a lot of money, so they're eating really poor food, that they're not getting a lot of fresh vegetables and fruit. There's also, in terms of inflammation, you also will see different things in the gut, whether it's irritable bowel syndrome or leaky gut. You can have small intestine bacterial overgrowth, which is probably more than you ever want to know, but there's just some information here so that if you have somebody who's got irritable bowel syndrome, or they have symptoms of that, it's maybe something you might want to check out. So the brain experiences inflammation from a variety of factors: stress, unhealthy nutrition, poor sleep, lack of exercise, overuse of alcohol, drugs, chemicals, and nicotine and tobacco are horrid for your brain. And so the food additives we've talked about, insulin resistance can happen as a result of some of the medications people are on, or the diet that people are consuming, hormone imbalance, chemicals in the environment, food allergies, drugs of abuse. So all these things can contribute to brain inflammation. Refined sugars are horrible for your brain. Processed and refined flours, white bread, cookies, pasta, crackers, and more. And when you think about people, even some treatment programs, right, they don't have a high budget for really good, healthy food. So they end up compounding the issue by providing some of these types of foods high in acids, dairy products, animal fats, caffeine, of course, alcohol, stimulants, depressants, etc. All that add to the inflammation of the brain. So environmental and lifestyle factors, exposure to toxic metals such as mercury, lead, history of infections, environmental toxins, pesticides, herbicides, food additives and preservatives, chronic stress, lack of exercise, sedentary habits, nutritional deficiencies, which we know that folks with alcohol use disorders have multiple nutritional deficiencies that should be addressed in treatment, overuse of antibiotics and acid blocking medications. So these are just some of the environmental issues that can also affect inflammation. So mental health and substance use disorders, in terms of Trauma and creating a self space. We all know that most of the people that we see have experienced some type of trauma prior to us meeting them or working with them. And we also know that two people can experience the same event, and one person can come away from it with relatively few symptoms of trauma, and the other person could experience that in a debilitating way that affects them for a very long period of time. And this is SAMHSA's definition of trauma, which most of you know, but it's there for you to read. We know that safety and re-traumatization, when we think about re-traumatization, I don't know that this gets discussed as much as maybe it should, but occurs when anyone experiences the repetition of a traumatic event or the onset of symptoms related to the previous experience. It could be a trigger. A trigger is a stimulus that sets off the trauma, a single environmental cue to the trauma, such as noise, a sound, a smell, or another person's presence can trigger a full flight or freeze response. All staff and all clients should be educated on the concept of triggering and taught skills for recognizing and being able to manage emotional distress. And I think treatment can be very traumatizing for people. It can be re-traumatizing for people. If you're working with someone this is severe and persistent mental illness, and they've ever had to be involuntarily hospitalized, that's an extremely traumatizing experience. How people are approached, their tone of voice, the staff's tone of voice, that can also be traumatizing. So, when we talk about having a trauma-informed care, that really is about too how the staff approaches the individual. So we look at some of the traumatic treatment experiences. Certainly COVID was traumatic for everybody. When somebody's being restrained, either physically or chemically, if somebody gets arrested and they're restrained. I've had people come in to be intaked from the jail and they're in shackles and handcuffs. I mean, that's traumatizing for staff as well as the individual. Noise can be very traumatizing. A jail-like environment, the more institutional your treatment program is, the more potential for re-traumatization. Inflexible, rigid staff just traumatize everybody. Something to think about. Lack of structure, conversely, that's also traumatizing. People with a trauma history need to know what's going to happen, when it's going to happen, and we have to be consistent. Poor communication is traumatizing. If you think about somebody who's got a history of emotional abandonment or abuse, and we aren't communicating well with each other, with them, it's very traumatizing. And then there's a whole host of other things that we can think about in terms of how treatment experiences can be traumatizing. So we want to, the principles which we are aware of are safety, building trustworthiness and transparency, having peer support, having collaboration and mutuality, having empowerment, voice, and choice, and then having cultural, historical, and gender issues addressed and validated. So assessing for trauma induced by treatment, rule out, not in. Okay, so what is our behavior? What are the client's triggers? Did I just say something? Was it my tone of voice? Was it the way I approached this person? I worked in a treatment facility where we had an individual in residential treatment who had been hospitalized in a hospital out of state. And the norm when somebody got agitated was they were taken down, which meant that the staff piled on, got them on the floor and put them in restraints. And this person was becoming dysregulated and he was in an open area, but 3 staff approached him and he just had this huge trauma reaction to that, because even though our staff were not going to take him down, they were not going to put him in restraints, just the 3 staff approaching him at the same time was enough to trigger a trauma reaction. change, being able to help people understand that we need to collaborate and we can't be in power positions. If we're in a power position, we're just going to re-traumatize that individual. Find ways to collaborate. Being able to develop a crisis plan with the individual. And then review episodes of acting out dysregulation as trauma response versus a personality disorder or a pathology. And that's so important. So many people get misdiagnosed with labels when in fact they've had a trauma response, oftentimes generated by us. So just something to once again stress for. We look at provider and system bias. And oftentimes you hear, and we've gotten better with our language. We used to hear about addicts all the time. Now we're hearing about people, an individual with substance use disorder, an individual in long-term treatment. And, there's a whole continuum and how, as providers in a system, if we continue to use stigmatizing language, we're also just reinforcing that stigma in the individual. So, using language that's first person, use empowering language, avoiding creating a victim, talking about the illness and not the individual. A person is an illness, a person is an individual, they're not a diagnosis. And when I went to work in one agency and we did a group with people and they sat around and they told us what their diagnosis was and what their medication was, but they couldn't tell us like what their favorite color was or what they like to do, right? They had interpreted and internalized their diagnosis to the point, is who we are. We look at the language that we use in terms of frontline staff in the trenches. We talk about people who are high functioning, low functioning, acting out, unmotivated, frequent flyer, people in denial. I know he's lying because his lips are moving. I worked with someone who used to say that all the time. People need to hit bottom, which is an old concept. We used words like alcoholic, junkie, addict, it's a habit, a lush, a wino, a boozer, a drunk, an alkie. And we look at the language that you hear sometimes in your own team meetings and then reframe that for people. So we can use language that presents the person in a positive or negative light. So we can talk about them we can use strength-based, hopeful, participant-centered language, or we can be pejorative. We can, say, well, he's a frequent flyer, he's never going to get it. And if we always need to be an expert, we're not going to really be able to be client-centered or connect with that individual in a way that's hopeful and empowering. So labels that stigmatize, this is just an example of, things that we used to say, in denial, which has been around forever, right? And if you reframe that to being ambivalent about taking meds or being sober, a con artist, the person's ineffective in getting their needs met. There's just different ways we can reframe things so that we begin to see people differently, and then they begin to see themselves differently, and then society begins to see them differently. Substance use assessment. Gone over this, but if you don't know this, here's different domains to begin to think about in terms of looking at substance abuse, misuse, and addiction. And then we look at the 6 dimensions of a multidimensional assessment from ASAM, which once again will provide a pretty good whole person, but not total whole person assessment. And these are available online. And some of you are probably already using these in your facilities. And then the levels of care. And the reason I put this on this is that, does everybody in our state have access to all levels of care? Does everybody have the resources to access those levels of care, even if they're there. And in a perfect world, this is a continuum of care that helps provide recovery for people. And, I think we need to do a better job of being able to provide these levels of care for everyone. And then we look at ASAM has co-occurring capable, which the primary focus is on a substance use disorder, but capable of treating people with sub-threshold or diagnostic, but stable mental health disorders. Psychiatric services are available on site or by consultation, and at least some of the staff are competent to understand and identify signs and symptoms of acute psychiatric conditions. And this is really important, especially if you're identifying your own treatment program, being able to use the ASAM capable and enhanced definitions. These are definitions that people are using across the country, and you're going to be able to then compare apples to apples. And in a co-occurring enhanced program, all staff are cross-trained in addiction and mental health and are competent to understand and identify signs and symptoms of acute psychiatric and substance use conditions and treat both unstable mental and substance use disorders concurrently. Treatment for both mental health and substance use disorders is integrated. And in a perfect world, this is where you want these folks to go in a program like this. Complexity capable, which they've added, is complex individuals and families have multiple co-occurring health problems with few resources, programs that provide a comprehensive integrated continuum of care. And a complexity capable program, patient-centered healthcare homes have been developed to meet the needs of this population, as well as assertive community treatment teams can also meet the needs of this population. So, I guess when we're talking about whole person care, we're talking about complexity capable, and how we develop that in our communities is really important. We look at mental illness. There are different ways to do psychiatric assessments. I talked before about them. The gold standard biopsychosocial evaluation, which some of us were trained in to do in the 70s and 80s, 90s. There's also the comprehensive longitudinal assessment. There's a contextual analysis assessment, and then there's also the differential diagnosis. So this is just the definition of a comprehensive longitudinal assessment, which explores the impact of life events upon symptoms of both disorders and vice versa. It defines significant periods or chunks of time to give you a visual representation of the historical cycles and symptoms and consequences. And this is something, if you can do on a piece of paper, you can do it on a blackboard or a whiteboard. It really helps you and helps the person you're working with look at kind of like their life in terms of functioning, in terms of when they started to use alcohol and drugs, when they started to have symptoms. And it's a great visual for people to help them kind of put it all together. And so this is just the structure of a comprehensive longitudinal assessment. Won't get into this in any great detail, but it's all there for you to look at. A contextual analysis assessment helps the clinician understand the context in which symptoms of mental illness and substance use arise, and the intensity and ways in which the consumers express and attempt to manage those symptoms. It focuses on the person's internal and external experiences, including their daily circumstances and their internal, external responses, feelings, thoughts, and behaviors, as well as the consequences of their behaviors. And the contextual assessment is an interactive style that often inspires individuals to tell clinicians stories about their daily life. So this is not one of those check boxes. This is a discussion. This is storytelling. And then, sometimes this is, a typical day exercise, right? And you begin with that. And then, this is the process of a contextual contextual analysis. Sorry about that. And so we look at triggers, response, and consequences. So triggers, internal thoughts, feelings, urges, moods. External could be situations, people, places, and things. The response are choices, decisions. Does the person lash out? Do they isolate? Do they use alcohol? Do they use drugs in relation to the trigger? And then what are the consequences of those decisions? So once again, this is very visual. It can be done to help the individual connect the dots. When, where, and why of a diagnosis. Once again, we want to rule out malingering and disorders like learned behavior, ineffective coping skills. We want to rule out drug-related causes, withdrawal, intoxication, rule out medical conditions, determine the primary co-occurring disorders, which may be three of them or four, right? There's rarely one primary disorder, and then we assess for all the things that we talked about earlier. So a differential diagnosis, we look at from a substance use perspective, a mental illness perspective, and a medical illness, and then you try to pull all that together to get a composite of what that person is experiencing. So recovery and resiliency. Resiliency is overcoming adversity. And you look at, on the left is Stevie Wonder, who's had this amazing career in life and has experienced so much. And then you have on the right, you have Bill Wilson in his younger days, who overcame the trauma of, I don't know if they ever really overcame the trauma of fighting in World War I, but he certainly had PTSD, he had depression, and he was able to get sober and co-found a way of life that's helped a lot of people. So I talked about this a little bit before. They've done research about what makes treatment effective. And so when we think about, you're designing your treatment program, you're designing your treatment plan, a lot of it's about the relationship. I would say the majority of it, of what makes treatment effective, is the relationship we develop with the people that we serve. So what the client factors, what they bring to the treatment, is 40% of what makes it effective. So another reason to do that whole person assessment. The therapy relationship that we have with that individual, that's 30%. Hope and expectancy is 30% of what makes treatment effective. And then the treatment model, whether it's CBT or MI or whatever, analysis, it's 15% of what makes treatment effective. So think about that. Where are we investing our time and our supervision and our talents? And then we think about, connection is the foundation of recovery. We know that most people start out connected, they have help, they have attachment to family and friends, and then the disconnection happens as a result of illness, isolation, whether that's mental illness, substance use disorders, medical illness, maybe all three. They become disconnected from the things that supported them and they felt attachment to. And then recovery is about reconnection. It's about, developing those relationships that make you feel supported, that make you feel happy, that make you feel like you belong. And, reconnecting with family, community, spirituality, whatever, that's really the foundation of recovery. So attachment is a deep and enduring emotional bond that connects one person to another across time and space. And connection and attachment are what feed our soul and our brains. And that's so important. And it's something I think is really needs to be kind of at the beginning of all this, right? Connection attachment disorders occur on a continuum from mild anxiety to reactive attachment disorders. They can be, disconnection can be as a result of adverse childhood effects, poverty, isolation, loss of personal values, and moral injuries that can happen as a result of having a substance use disorder or a mental illness. Reconnection, it's about engagement and treatment and mutual help. For some people, it's about a sponsor, spirituality, friends, work, school, hobbies, talents. be music, art, dance, whatever you can reconnect to. Resiliency is the ability to overcome challenges of all kinds, trauma, tragedy, personal crisis, plain old life problems, and bounce back stronger, wiser, and more personally powerful. Conditions that help create resiliency are caring and support, high expectations for success, opportunities for meaningful participation, positive bonds, clear and consistent boundaries, life skills. Does this not sound like a trauma-informed environment? Personal resiliency builders are relationships, sociability, ability to be a friend, ability to form positive relationships, being of service, giving of yourself to help others, other people, animals, organizations, or social causes. Humor. Having a good sense of humor is a great resiliency builder. Also having inner direction, basing choices and decisions on internal evaluation, perceptiveness, being insightful understanding of people and situations, having adaptive distancing from unhealthy people and situations, and having autonomy, a positive view of personal future. So when we think about treatment planning, are these the things that we are including in our treatment plans in terms of objectives? Positive view of personal future, flexibility, love of learning, self-motivation. These are all things that we can build on that will help that person enjoy and engage in recovery. And then being competent, being good at something. Everybody can be good at something. You just have to find what that is. And once again, part of the whole person assessment. What are their strengths? Having a feeling of self-worth, having a personal faith in something greater than themselves, perseverance, keeping on despite difficulty, not giving up. But that's one of the great things about a 12-step program, is that people get that kind of support every day or a couple times a day if they want to get to a meeting. Having being able to express themselves through art or dance or whatever, music is so important. And then as staff, we can help communicate this by really focusing with the individual on what is right with you is so much more powerful than talking about what's wrong with you, and focusing on the person's strengths more than their problems and weaknesses, and asking, how can these strengths be used to overcome problems? We used to talk about, back in the day, there was a man who he would walk 3 miles in a blizzard to get to the American Legion after work so that he could drink and do his thing. And when he got sober, the AA meeting was 2 blocks away, and he said, I can't go out in the snow. I can't do that. And so we tried to show him, well, yes, you can, because look at what you did, look at all the resilience you had to get to the VFW. So being able to flip somebody's behavior around can be very helpful too. So helping the person develop and enhance the conditions that support resilience. It's important for us to have patience. It's important for them to have patience, that it takes time, and giving people the time that they need is really important, being respectful of that. If you're in an agency, having an opportunity for the participants, consumers, to have meaningful participation, whether that's participating in the hiring process, giving feedback to staff, providing family education and support to their family members, involvement in self-help groups, team sports, there's a lot of ways for people to have that. This is the resiliency wheel that we've just talked about, which is you can use to develop programming and or a treatment plan, and recovery capital. Recovery, this is definition by the Recovery Research Institute, is from a substance use disorder is defined as a process of improved physical, psychological, and social well-being and health after having suffered from a substance-related condition. So recovery is multidimensional, and we've talked about this. There's a physical component, a mental component, a spiritual component, the kind of positive be all you can be, and recovery should be individually defined. Holistic recovery, you're looking at all areas of the individual, which is, once again, when we look at the whole person assessment, it all ties into this type of holistic recovery treatment planning. Developing outcomes. So this, I think, is so true. So all year long, I've taught each of you to learn at your own pace in your own personal style. Set goals for each of you individually to help you reach your own unique potential. And now the results of that will be measured with a standardized test. I mean, is this not what we experience? So when we look at the dimensions of recovery, look at health, home, and purpose, and community, and these can be things that we can measure in terms of outcomes when it comes to our recovery community. And recovery capital is, you look at the person's strengths, their personal strengths, their social strengths, their community strengths, and then you look at what are their unmet needs and their barriers. And for an example, an internal capital is health, hopes, values, aspirations. External, access to housing, transportation, having money, benefits, friends and family. Individuals with high problem severity but very high recovery capital may require few resources to initiate and sustain recovery than an individual with moderate problem severity but very low recovery capital. So the idea here is the more recovery capital you have, the more you're able to address and manage conflict, stress, and issues that come your way. Social capital is able to start a conversation, speak in meetings, connect with peers. And then external, having those networks and commitment to others. Community capital is, all the things we've talked about that are essential for somebody to maintain their recovery and stay in recovery. And we talked about barriers, and then we look at how does treatment support or mitigate some of these barriers in terms of hopelessness, untreated mental illness, substance abuse, low self-esteem, learned helplessness. And then the external, once again, accesses to community resources, lack of insurance, lack of meaningful activities. Individuals' perceived unmet needs to recovery, their perception of shortfalls or unmet needs in the professional or medical support is really important because that's a barrier to them accessing recovery. And then the individual's perception of a lack of help they have received in areas such as housing, substance abuse, it leads to that hopelessness and sense of futility. Nothing's ever going to change. So this is a recovery capital scale. That's an example of it. You can look at this and you can give this to people and measure where they are in terms of their recovery capital. And this tells you where this is the whole tool for you. Resiliency, the ability to become strong, healthy, or successful again after something bad happens. If we can focus on resiliency as opposed to what's wrong with people, this really is kind of how to fast track people into bouncing back from a relapse or getting help after an incident of it may not be a relapse, but it may be a medical condition, it may be a family condition or whatever. So being able to provide the person the conditions that support resilience. It's important for us to have patience for people who keep saying that over and over again, right? Resiliency outcomes are improved self-esteem, less trauma, community integration, recovery, interdependence, moving forward with life goals, increased self-confidence, and healthy relationships. And then here's some example of resiliency-based programs if you want to Google them and find out about it. And that's the end of my presentation. My email is there. Thank you for spending this time with me. And I look forward to hearing from you for any questions or comments. It would be great. There's references and then foods. This is a resource as well. It's a documentary about food that matters. And then this is a program in Wisconsin that I stumbled upon in terms of planning and implementing for screening for fetal alcohol spectrum disorders, which I think is awesome. So thank you all. Have a great day.